Hi everyone, this is Aditya. I'm bringing you a quick podcast on the topic of polyuria. This is in conjunction with our basic science lecture on diabetes. So let's get started. So like any lecture, we have our learning objectives. Our learning objective today, understandably, will be focused around the topic of polyuria. Polyuria is defined as excess urination. So we want to be able to define what polyuria means with patients who complain of frequent urination. There's a very strict definition, if you will, by which we evaluate these patients. We want to look at the causes of primary polyuria, what conditions might result in excessive urination. We also want to talk through kind of what sorts of questions should you ask anyone coming in with urinary symptoms, not just frequent urination. Any type of urinary symptom, the questions that you ask kind of change. Next, we want to talk through the basic lab work that you might order in trying to evaluate and understand these patients who present with frequent urination. Then we're going to ramp it up a little bit and talk about the water deprivation test and its diagnostic role in these types of patients. And then finally, we're going to round out our discussion today with just a cursory look at some of the treatments that you could offer patients with polyuria. So what is polyuria? Polyuria is defined as excessive urination. Makes sense, right? Poly meaning a lot, urea meaning urine. So a lot of urine. So basically the strict definitions we use for these patients would be in adults, we look for urine output greater than 3 liters per day. The normal urine output that any normal adult would have would be 1 to 2 liters of urine. So anything greater than 3, we start to get concerned, and we would define it as polyuria. For children, that marker is a little bit lower. They're smaller individuals, so understandably it would be lower. So the urinary output would be greater than 2 liters per day, and that is what we would define as polyuria in children. I have a note here for you guys just to be careful because we're going to start throwing around a lot of different terminology that might sound similar but is distinctly different from each other. So polyuria is not the same as nocturia, is not the same as polydipsia, is not the same as dysuria. These are all different terms. The one of which we're talking about today, polyuria, we've already defined as excessive urination. Nocturia is defined as excessive urination at night. Polydipsia is excessive thirst. And then dysuria is painful urination, or pain on urination. So what are some of the causes of primary polyuria? I make the distinction here that we're talking about primary polyuria. There are a number of diseases where excessive urination is kind of a byproduct of the disease process, whereas here, these diseases cause excessive urination. That's kind of the primary symptomatology that they're associated with because they act directly on that mechanism of urination. So Amog has talked about a number of these in his podcast, so I'm not going to talk through the specifics of each of these, but lead it to be that diabetes mellitus is probably one of the most common causes of primary polyuria in the country. You have excess glucose, which spills into the urine. That glucose draws in water, creating greater volumes of urine, and understandably, you'd need to avoid that. Primary polydipsia, understandably, if you drink a lot more, you would then have to pee a lot more. Central diabetes insipidus and nephrogenic diabetes insipidus. These are both conditions associated with vasopressin or ADH, which stimulates the ability of the collecting duct to collect water. So if you have an insensitivity to this, you have the water remaining in the filtrate and then ultimately creating greater volume of urine in your bladder, which you would then need to avoid. Some other conditions associated with polyuria but may not directly lead to polyuria, but these patients might come in complaining of similar symptoms, would be infections, specifically UTIs. These patients may not necessarily complain of excessive urination, but they may complain of increased frequency. They may need to feel the need to go more. They may not necessarily void a whole lot each time they go, but they're going to say, I'm going to the bathroom more and more than I used to. And so that's the typical kind of complaint you'll hear from patients. A condition associated with older men, you may have heard of it, BPH or benign prostatic hypertrophy. This condition is really readily associated with nocturia, the excessive urination at night. These gentlemen complain of having to get up 2, 3, 4 times at night to go to the bathroom. That's not normal. Most people maybe only get up once every now and then to go to the bathroom. These gentlemen, unfortunately, are getting up at least once a night to go to the bathroom every night. So how do you interview patients who present with urinary symptoms? Now remember, we're keeping this general. This is for anyone coming in with any urinary complaint. I think it's important to ask some of the same questions because you never really understand what's going on. People may misinterpret what is actually happening. So you need to kind of get everything straightened out, and you need to ask the right questions to do that. So in interviewing for a patient with urinary symptoms, you want to ask kind of straightforward questions regarding their urine. This unfortunately does not have a cute mnemonic like old carts or old charts or vitamin or vindicate. These are more straightforward kind of common sense questions to ask. You always want to ask how many times do they use the restroom in any given day. This is a really good baseline question to ask. This is going to define kind of what the rest of your questions are going to look like. You obviously want to ask them if they wake up at night to go to the bathroom. We just talked through different conditions that might present with nocturia, so it's important to understand if they're waking up at night to go to the bathroom versus if they're just strictly going more in the day. You want to ask about if they have an increased urgency to go to the bathroom. Urgency is not the same as actually going to the bathroom. Patients may complain of, I feel the need to go to the bathroom, but then when I get there, I don't have anything come out. You might ask if they have ever had an accident, if they haven't been able to get to the bathroom fast enough because honestly they couldn't sense that they needed to go to the bathroom. That obviously speaks to some underlying pathology that could be concerning. You might hear complaints of trouble starting and stopping. So what that means is that patients will go to the bathroom, they'll start, and it'll be a little bit delayed in terms of how they start, and then once they start going, it'll stop, and then they'll start again, and they'll stop, and they'll start again. So these men have kind of an irregular stream. So it's always important to ask if they've had trouble starting and stopping. Understandably, you want to ask about the gross nature of the urine. So you want to see if there's if they're going to complain of any blood in the urine, if they complain of any changes in the color of the urine, if they note any smells that arise from the urine. And then more straightforward, you want to ask them if they've been drinking more in any given day. And coupled with that would be an increase in thirst. So now that you've asked all the questions you want to ask for these patients, how do you actually go about evaluating them? What are some of the things you want to order, some of the things you want to look for? So understandably, like we keep talking about in all of our sessions and all of these lectures, is that you want to order lab tests and you want to answer two kind of basic questions. What are you going to get out of this lab test, and why are you particularly ordering this lab test? So the workup really is kind of tied back into your differential. So if our differential included a UTI, we might want to consider getting a CBC to see if there's an elevated white count. If we're concerned about the osmolality of our urine, we need kind of a baseline to compare it against. So we want a BMP to kind of look at what the sodium levels are to get a better sense of the serum osmolality as opposed to the urine osmolality. If you're concerned about diabetes, of course you're going to want blood glucose, and that would come in a BMP. And then finally, we go back to our good old urinalysis. Here's really where it plays a starring role. You want to check urine osmolality, and you want to make sure that there's no glucose in that urine. So you want to check for urine glucose. And the urine glucose and urine osmolality are kind of basic components of the urinalysis. So what do you do once you think you might have someone who has primary polyuria? You might consider doing something known as the water deprivation test. And the water deprivation test is really helpful because it'll help distinguish between polydipsia as a cause and diabetes insipidus. So this is assuming that you did the urinalysis and you didn't necessarily find any glucose in the urine. So now you're left with the three other causes of primary polyuria, one of which would be polydipsia, and the other two are the different versions of diabetes insipidus. So the understanding is you stop them from drinking any water. So you admit these patients, you stop them from drinking any water, and then you look at what their urine osmolality does. So you measure the urine osmolality before you stop the water, and then you measure it after you stop the water, and you try and look for a difference. Understandably, if you stop drinking water, your urine should get more concentrated because your body is trying to reserve that water. So if they have primary polydipsia or psychogenic polydipsia, the idea would be that they stop drinking water, therefore the urine osmolality should increase, indicating a more concentrated urine, and so that would confirm polydipsia. Versus diabetes insipidus, where it doesn't matter how much you're taking in, the body's incorrectly insensitive to ADH. So the urine osmolality won't change between the two conditions. And then once you have kind of narrowed down that it might be diabetes insipidus, then you can administer desmopressin or synthetic ADH to see what it actually does to the osmolality. If the osmolality changes once you give ADH, then it's probably more of a central diabetes insipidus, versus if you do the desmopressin and nothing really changes, then it's probably a nephrogenic diabetes insipidus. So finally, we're going to talk about treatment. There's really, these are really inelegant solutions for these patients. One of which is you might want to just prescribe a journal that allows them to document their habits. These are things that urologists will frequently do with their patients. They want them to note how much they drink, and they also want them to note how much they go to the bathroom and how much they void. So you give them a container, you tell them to measure how much they urinate. So they void into the container, they measure it, and then they dump it into the toilet, and then they document that in their journal. And then just the same, they document every soda, every water bottle, every cup of coffee they have, and how much they think that they're taking in it on any given day. And it gives the physician a lot more information to kind of work through and understanding, is this person going more frequently? Are they drinking a lot? Are they not drinking that much and still going a lot? It really helps kind of narrow down everything and get a better sense of what's going on. Understandably, if they have one of the other conditions like diabetes mellitus, you just need better glucose control. So you want to get them on a better regimen. If they haven't ever been on a regimen, this is the first time you might consider testing their A1Cs and doing a whole diabetic workup. And then also getting them in contact with diabetic counseling and diabetic education, because they need to change their diet. They're probably going to get started on some drugs, and things are going to get better if they stick to it. Now, diabetes insipidus is a lot more difficult to treat, and there are different forms of diabetes insipidus, so that kind of changes how you treat it. But basically, the body's insensitive to ADH, or it's not producing enough ADH. So for central diabetes insipidus, you could consider just replacing the ADH. But you can also give these patients diuretics, which will help their ability to void. But you also want to consider a low salt diet, because the low salt diet will help them kind of retain some of that water. So that's it for primary polyuria. Any questions, as always, you're free to email myself or Amog, and we'll do our best to answer it. Hopefully you learned something. The condition of frequent urination is one that you'll see quite frequently in the outpatient setting, and it's kind of a nice disease to work through and to help these people, because there's quite a bit you can do. Thanks, and good luck with the sessions this week.